So today I'm going to be discussing an important and often overlooked topic in mental health assessments, barriers to mental health treatment in African American community, with particular attention to the role of religious belief and practices. I'll be focusing on the barriers to treatment participation scale as an assessment tool for understanding these complex factors. The current slide shows the basic information regarding the barriers to treatment participation scale, but just some other factors. It is a 44-item scale that has been used in prior studies to identify factors that prevent patients from obtaining mental health services. While it was originally developed to access barriers in children, the expanded version now has been validated for use in adult populations and including the African American populations. The scale assesses multiple dimensions of barriers of treatment, including practical obstacles, perceptions about treatment, and personal family factors. It's self-administered report. It takes about 15 to 20 minutes to complete. The respondents rate each item to indicate the degree which various factors represent barriers for them seeking and continuing the healthcare treatment. Scores yield subscale scores for different types of barriers, allowing clinicians and researchers to identify which specific factors are the most important or the biggest for the individual client or community. This information is invaluable for tailoring interventions and addressing the most pressing obstacles of care. So, on reliability, um, this assessment provided the 7 validated barrier categories: cause stigmas, treatment fears, doubt about clinician effectiveness, perceived lack of needs, logistics, and concerns about confidentiality. Each demonstrated distinctive measurement properties, suggesting that the BTPS captures multiple dimensions of treatment barriers rather than a single global construct. Validity, the BTPS demonstrates strong constructs validity through its ability to identify theoretically meaningful barrier categories. Significant relationship emerged between age, gender, income, education, insurance status, and ethic affirmations of belonging among several of the barrier scales, supporting that the instrument sensitivity to psychodemographic factors known to influence treatment access. So I know this presentation is supposed to be about 5 minutes, but I think my personal critiques are going to take it a little bit over. The BTPS offers several important strengths when assessing barriers in the African American community. First, its multidimensional structure captures the complexity of treatment barriers, recognizing that obstacles exist at individual, interpersonal, and systemic levels. This comprehensive approach aligns well with the multifaceted nature of disparities in African American mental health care. The instrument itself is validation, specifically with African American population using rigorous psychometric methods like the Moken scale analysis, provides confidence that it measures relevant constructs in the community. Unlike generic barrier assessments, the BTPS has demonstrated cultural relevance. The brevity of administration makes it practical for use in diverse settings, including community healthcare centers, churches, and research studies. Results can directly inform intervention development by identifying which specific barriers are more salient for individual clients or communities. The limitations, however, it's important. Limitations must be considered. First, the BTPS was originally developed to assess children, and while expanded for adults, some items may not fully capture the unique barriers faced by African American adults across the lifespan. The self report format assesses that participants have insight into their own barriers and are willing to disclose them. Given that the stigma is a major barrier, and cultural beliefs about mental health illness may emphasize self reliance and the importance of keeping problems within the family, some individuals may underreport certain barriers or behaviors. The BTPS may not adequately capture the dual nature of religion as both barrier and facilitator. Something in simple ratings of religious barriers may miss the nuanced ways faith communities can support or hinder treatment seeking. Finally, 14 barrier categories that have been identified in quantitative research with African Americans suggest that standardized scales may not capture all relevant barriers, particularly those related to historical trauma and medical mistrust stemming from events like the Tuskegee experiment and contemporary experiments of racism in healthcare settings. Alternative assessment tools. We can look at qualitative interviews, semi-structured or in-depth interviews allowing participants to describe barriers in their own words, providing rich contextual information about individuals' approaches or environment and institutional factors. Community-based participatory research, collaborative partnerships between universities and African American faith communities can identify barriers to community engagement. Focus groups with clergy and congregation members, given the many African American clergy members believe that they were not well prepared to address mental health problems. Focus groups can assess both barriers perceived by the community and gaps in clergy training. Culturally adapted screening tools, self-reporting service kiosks that screen for mental health problems and acquiring background information can be integrated into community settings like churches, along with culturally tailored mental health educational resources.